Thank you, everybody. Thank you for being here. Not long ago, AI became the talk of town. We've heard it from Google to Copilot to NVIDIA chips. And about 8 months ago, I received an email from famous investor, Jim Cramer, stating why investors should enjoy AI while CEOs figure out how to use it. I'm proud to say that already several months before, I had a conversation with our CEO, Sanjeev Lakhanpal, about how he was already envisioning AI and how to already using it in our medical field. So with little more introduction, I would like to welcome to the podium Dr. Sanjeev Lakhanpal, who's going to give us a conversation about AI in medicine. I don't think.
Thank you, thank you. So, like I said, this talk's going to be a little different than lymphedema, but this is the kind of place where I grew up in India, and you know, the bicycle that I would ride to go to work would go through these fields, and around harvest time, which would be mid-March to early April, this place would just be full of happy farm laborers who would come from all the neighboring states, a lot of partying in the evening, and over a period of about a month or so, all these wheat fields, this is wheat for those of you who are not familiar with this, and the wheat fields would be taken down, the wheat would be threshed out of the stem, and it would just be the time of our lives for that period over there. And that's the time when, you know, this whole thing started that, oh, you know, they're going to bring in these machines from America, which are going to be called combined harvesters. And these farm laborers are sitting and they're just chatting, how the hell will this machine know the precision I use my sickle with, and I cut the stem of this wheat, and how I take the grain out? Oh, this is never going to happen. And as I got into 8th grade or so, one combined harvester working 2 days would take care of all these fields, and these laborers were, well, they had to find other ways to make a living. You know, the reason for my talk today is not to scare anybody. It's when there is uncertainty, then we get scared. When there is certainty, that's when we really have to prepare for it. And what is coming is certain. It is going to make our lives better if we are ready for it. And if we are not ready for it, we will be no different than those farm laborers who just had thought what they do just cannot be replaced. So also, I'd like to simplify the jargon a little bit. It's so confusing. Everything they say is AI, right? I mean, the other day we had somebody selling ultrasound machines which were AI-driven to, you know, you get vacuum cleaners that are AI-driven, so you're like, what exactly is AI? And that's what I would like to touch. You want to start my timer? I mean, just so that way I have an idea. So all this is AI. So from a simple, you know, it's called a first-generation robot, to a fifth-generation, you know, super intelligent creature that someday will be created. That is all AI. And the difference as you go through different stages of this is essentially you have simple motor activity going on, and then you have some kind of sensory input also coming, which could be radar, sonar, whatever the way it is. And the response is to that. So that's how the second generation comes. Then you gradually have, you know, there will be singularity, which a lot of us have read about. And that's when you have a normal human being, right? When you have somebody with my kind of intelligence, that'll be singularity. When you have somebody with Peter and Nikos' kind of intelligence, that'll be artificial superintelligence. So it's just these stages that we go through. But on the bottom of that, if you see where we are today, it's, if we were to look at the evolution of life, we've still not reached the dinosaur stage for artificial intelligence. And a word speciest has been thrown out there, that this is truly a new species that is coming. And whether we believe in it or not, I mean, that's up to us. But our species, which is so far, we think, the smartest, will not be the smartest anymore. And there will be another species that will be smarter than us and which will go through their own evolutionary cycle. Now, why now? Again, if you look at the graph here, it's very, very simple that there's exponential data growth. There is the cost of data storage has gone down. And if you look at it earlier, we used to talk about megabytes and, before that kilobytes and then terabytes. I mean, that itself, when I heard the word terabyte, I thought I'm really smart. And now they're going into petabytes and zettabytes. I mean, it's just endless how much data they can store. And truly, anything we do in life can be reduced down to data. So whether we think about intuition, some would say intuition is basically your genetic makeup, and we have data in your genes. What we learn here, everything that was being talked about, it is all intellect, it is data. And this species, if that's what it is going to be way smarter than us about data. Yesterday, that question was asked about, vasodilatation, and I felt like an idiot that I didn't remember prostacyclin and nitric oxide. I mean, 20 years ago, that was the first thing I'd say. These machines don't forget. So once they've learned, it's going to be there. And just a simple thing that there's input, which is all data, whether it's NLP, speech, visual recognition, processing, your knowledge, memory, learning, or outputs, which will obviously be mechanical outputs. It is essentially a data game and speed of data processing. Again, in trying to make some terminologies accessible and easier. So if we just look at the red rectangle that I've made is what we are kind of talking about currently, which is, so when you look at AI trends, there's AI, and then there's different stages of AI: narrow learning, general artificial intelligence, and super intelligence. We are still in the narrow learning stage. And then these terms are thrown out, which are different types of learning: machine learning, deep learning, generative AI being different than general AI. And then all these different types of learnings depend on certain ways that machines learn, methodologies of learning, which would be simple algorithms or more complex algorithms, language learning models, which is what we talk about when we do whether it's BARD or the Microsoft version of that, and then neuronal networks. So machine learning uses algorithms and LLMs, deep learning would use more of neuronal networks, and generative AI uses all of them. But we are still in the infancy stage of learning. Now, this slide is here to show that what truly, initially when artificial intelligence, the term was coined, they were talking more about that this is when machines will be able to think for themselves, right? So when you look at a printing press, a quick, fast, rapid printing press was an amazing thing, but a printing press could not create ideas of its own. It could print the Bible, it could not write the Bible for you. AI can actually write a new Bible, think a new Bible, write it, print it. That's not fair. You just got me to minute 43. Okay. So, and it could print all that as well and figure out how to disseminate it. Ken Wen is on Twitter at this time and this time and this time, so if I want Ken's attention, that's where I need to go. All of a sudden, this AI's religion is going to be more dominant than any other religion and then they also know who is going to react. So, my time kind of got run away.
You have a little longer.
You have a little extra.
No. So,
10 seconds.
Okay, let's talk about algorithms. So a very simple way for me to understand how this is going to impact us is, let's go back to when we worked in the ICU, right? A patient has a certain CVP, certain pulmonary capillary wedge pressure, urine output, heart rate, stroke volume. We'd be given all that. And now think of this. This machine can have endless data entry points, which would include, in addition to what we think about, it would include what's your genetic makeup? What are the key points of your family history, right? It would have access to all of your earlier, if you ever had a pathology, you had some kind of a biopsy, a colon biopsy, and not just that, it'll then decide whether it's going to give you niacin or it's going to give you epinephrine, and how did your kidneys react to that? Not just that, how soon did you go home, and how soon did you have to have a readmission? And like I said earlier, I took my medical school admission test, then I took my general surgery in India, cardiac surgery here, venous medicine, and if today you ask me what happened 30 years ago, I don't remember. These machines will remember, and there's just logically no way my intellect can keep up with this, and it should come. I mean, if we want progress and we believe in if the world should be a better place, this is going to do a better job than us. And what are the early tests showing? So MedPalm is, the Google platform was Palm, which is the same platform that Bard uses, and MedPalm is their medical suite. In 2022, they did better than an average person. See, all of us feel when a machine or something else comes, they need to beat the top 5th percentile. That is not true, right? A machine has to beat an average physician. In 2022, they beat an average physician in taking the USMLE test. 6 months later, they were at 86.5th percentile, which was way better than an average physician. And this was already 8 or 9 months ago that I could collect the latest data. This keeps getting better and better. And when they tested them for different things, different characteristics that a physician needs to have, it was only one area where the machines did not do as good as the physicians, and which was about accuracy of information. So you'll say, oh, that's the main thing. Of course it is. But the data is there. It's the probes that would go to pick up data, started picking up too much data. And that's a problem that they are seriously fixing, and it's sooner or later going to go away. So rushing through the other slides, this is if you want to play with it, it's called the MedPalm 2. Most of us currently do not have access to this. It's all the studies are happening at the Mayo Clinic and the NIH. The public is still not ready to accept it. They're ready to accept that physicians get support from artificial intelligence, but they're not ready to accept it directly. These plans, if you go on the internet, are already there for, ultimately it's Google, Microsoft, NVIDIA. I mean, these are the main players that are going to, one way or the other, run this, that it's a whole medical suite. Think of it, there's nothing that we do other than surgery so far is safe, like, till robotics comes. And it's safe is not the right word. It's everything is safe as long as we get ahead of the game. We should not think that this is paranoia. This is reality coming our way. We got to get in the game early. I'll tell you, for CVR and our little baby steps, this whole big hoo-ha that we made about the smart template, that's an algorithm, right? CVR deals with over 600 insurances throughout the country. Our denial rates were 9.5% to 10%. Now imagine 600, maybe out of 600, probably 80 of them are what we do by and large, but all 600 had different data points of what they need. Somebody needs 6 weeks of compression stocking, somebody needs 10 weeks of compression stocking, somebody wants Verithena, somebody else wants. So the only way we could do is with the smart algorithm, that if you're in Alaska and you want this done, this is the insurance, these are the 5 things it allows, and with that, our denial rate has gone down to 1%. And that too is when there is still a backdoor to bypassing the smart template, because you feel that how can this even happen if we are already doing what the insurance companies are saying? So at a very simple rate, and I shudder to call it artificial intelligence, but it is It is by definition that. And it can really help us. It can help us do better and better. So our job has to be what so far AI cannot do is the ethics and the morality of things. It's going to get there, but for the next 10, 15 years, I think as long as we remain strong patient advocates and use everything that artificial intelligence is bringing for us, we will be ahead of the game. This will become our friend, and closing our eyes is not going to be the right way. And also, let's all, for the future of humanity, hope we have a soul. That's what that halo shows, because if we don't have a soul, then this species is definitely going to outdo us. Thank you, guys. Thank you very much.
Thanks. Our next speaker has two loves. He's going to continue to share his passion of vascular sonography with us, but he also has a passion for South America, specifically the country of Brazil. Please welcome to the podium for the third time today, Professor of Surgery and Radiology, Director of the Vascular Lab at Stony Brook University, Nikos Lavropoulos.
You know, Sanjeev, before I go to my talk, I have to comment on what you said. I mean, AI is a great thing, but think, Sanjeev. You know the philosopher Partha Sarathi, right? And he's an Indian guy. He wrote a book called The Fall of the Human Intellect. You don't have to read the entire book, but it talks about, a lot of things you said here. But if we lose our intellect, it's basically losing what Einstein said in 1928, imagination. And imagination creates AI, is superior to AI, and is the only thing can go forward, because imagination encircles knowledge is better than knowledge, because without it, you can't go anywhere. Anyway, go to my talk now. This is a patient. Now you see a typical image of the right common iliac artery compressing the left common iliac vein over the fifth lumbar vertebra. On this particular patient, both in the supine and standing position, the vein has the same diameter. This is what we call a fixed stenosis. In a patient like this, with appropriate symptoms, then you can treat the patient, and the patient is likely to have benefit. Not always, but most likely. Now, what is a hemodynamically significant lesion? Well, in physics, in order to have hemodynamic significance, you have to have a flow reduction or pressure reduction or both across the lesion. But this is true for a single tube, right? And more and easily understood in the artery. In the vein, you have collateral veins bypassing the obstruction, you have velocity increase, diameter increase, or both. And in the vein, it's not like the arteries that they change by a little bit. The vein diameter, I showed you in my previous talk, the collateral can be bigger diameter than the actual vein. So these things we don't take into the equation, don't know how to measure. And the thing is, a patient can have the lesion I showed you earlier, can be symptomatic or asymptomatic, or be symptomatic only during physical activity. See, when we do things, we don't put this into perspective. What are the methods of detecting obstruction? To be planimetric evaluation with diameter and area reduction on IVUS, presence of collaterals, flow patterns, which usually reverse or non-phasic flow, velocity change across the stenosis, the balloon test demonstrating a clear waist, right, and pressure measurements across the stenosis. Pressure measurements are invasive and not always indicative. If you have a pressure gradient of more than 3 millimeters of mercury, it is guaranteed that you have, a problem. But if the pressure gradient is not there, it does not mean you don't have a problem. I don't want you to detail, but basically, we do currently only morphologic evaluation. Ideally, we should do morphologic plus hemodynamic evaluation. In our paper, this is only for post-robotic limbs. Here it's easier. When your iliofemoral veins are occluded, you're most likely to get into trouble, and 18% of these people have venous claudication, which you don't see when you have an isolated stenosis in non-thrombotic iliac vein disease. I want to go here because here is some misunderstanding. Dr. Azu, in his original papers, he mixed post-thrombotic disease and non-thrombotic disease. And he claimed widely that a 50% area reduction by IVUS, which is 29% diameter, right, can be responsible for the signs and symptoms. I admit this could be true in many of the patients with post-thrombotic disease, but I cannot figure on my brain yet how a 29% diameter reduction without anything else going on in the human body to give you symptoms, right? And clearly there's no data to support it. And I want to come across to this. This is not the best of the studies, but it's the best study we have. When you look at the IVUS and venogram, when you look here, in non-thrombotic patients, standing a vein with a diameter of more than 61% diameter reductions by IVUS, 61% diameter is over 80% area. This is not 50% area, which is 29% diameter. It's 61% diameter, which is over 80% area. So for those of you using in non-thrombotic disease the 50% area, please rethink of what you're doing. And here is a beautiful study from the Netherlands showing the illusory angiographic signs. They say, Nikos, I see collaterals. Well, this is normal volunteers from Holland having a venogram, having at least 2 venographic signs proving a stenosis, yet have no symptoms. So, again, think of what you're treating. Please, treat the patient, not the lesion. It doesn't matter if it's carotid plaque, it's SFA stenosis, or iliac vein stenosis. And in this study, again for the Netherlands, it was shown that 24% of people did not respond to treatment, and 14% that treated for non-iliac vein, non-thrombotic iliac vein stenosis became worse. Don't forget that patients with NIVEL are often relatively young, have normal life expectancy, and tend to remain in the iliac veins for a long time. I'm not saying not to use them. I said to use them when appropriate and with caution. I'd like to show you the patient we demonstrated in 2019 in Venus Symposium. This patient has a tight stenosis in the spine position of the iliac vein on the left panel. When you start out the patient, the vein from 2.5 millimeters became 11 millimeters. So where is the stenosis? Yet, there is another study from Poland using IVUS. And to do this properly, they put the IVUS from the jugular vein, so they can do the IVUS on the standing position, supine, and also having the patient on the lateral decubitus position. And this study, they demonstrated very clearly that is positional iliac vein stenosis in the majority of the cases. And I come back to the first slide. If you have a patient like this, which happens 1/3 of the time, have small or no positional change, you have a fixed stenosis with appropriate symptoms, that is the patient to be treated. What I like to tell you, this is a beautiful paper from 1981 from Dr. Eklof, Einarsson, and Albrechtsson. And there you can see, I don't want to go through all these details, but this paper having iliofemoral obstruction, right, because of previous thrombosis. Even these patients, look, 12 of these 50 patients had pressure values and difference similar to those with normal iliac veins. Their pressure turned to pre-existing exercise levels within 20 seconds. No progressive pressure elevation despite repeat exercise periods. See, even people having obstruction, post-thrombotic of iliofemoral veins have no symptoms and no pressure changes. And that's why I was telling you earlier, right, if the pressure gradient is not there, it doesn't mean the patient is normal. Now look and see a patient with heel ulceration, class 5 disease, female with swelling and pain over the 15 years, has previous femoral-popliteal DVT 9 years ago, treated with anticoagulation for 6 months, no recurrent events. Look now, this patient has a very high velocity at the left common iliac vein, right? And look, the ratio is 3.9. And if you do the planimetric evaluation, the patient has a remaining lumen of 1.4, and the vein further down is 11.4 for an 87% diameter stenosis. But look now at the lesion, the remaining lumen. You see, the posterior wall, like described by Cockett originally, is very well thickened and has a lot of collagen, right? So this is a fixed stenosis in a patient with skin damage and ulceration that you should be treating. And this did not change by putting the patient on standing position either. But here is another patient. How many of you have seen a CAT scan like this, where the yellow arrow is this tight stenosis from the artery over the vein? This a female, 28 years old, with no pregnancies, flank pain and frequency over 10 years. Last 6 months getting worse. Symptoms more pronounced on studying. Listen, more pronounced on studying the symptoms. And BMI of 19, around 20. Look at this patient. Left common iliac vein, positional stenosis, right? On the supine position on the left, the vein is only 2 millimeters. On studying is 9.3 millimeters. So what is the stenosis? What are we treating? And don't forget, this patient had more symptoms when he was studying. Well, if he's studying, there's no stenosis. Just rethink of what we're doing. And this is another patient live to see that, you know, a tight stenosis of the iliac vein at 2 millimeters. And you see very nicely on the supine position, the same with the color. And then starting up the patient, where is the stenosis? 13.3 millimeters. And not only that, hemodynamically, you see the color on the left is blue and blue. The iliac vein, the entire iliac vein should be red on this position. When you start the patient, it became red. Even the entire iliac flow normalized. So if you see the venogram reverse flow, if you start the patient, the flow is going to normalize. So unnecessary stenting can be avoided in many patients. This is very important since many of these patients are younger. This work warrants further, research to be done towards improving diagnostic criteria and preventing overtreatment. How do you select the patients? Symptomatic patients with iliac vein stenosis of more than 6% in diameter that is fixed, having appropriate symptoms, pain when all other causes have been excluded, and pelvic symptoms, more likely when collaterals are present and not varices. In patients with both obstruction and varices, more careful evaluation is needed. What to do first, or eventually both, right? And I think I need to finish here because I'm 30 seconds over. Thank you.
Thank you, Nikos. With the evolution of medical techniques comes new complications. What used to worry us with E-hits became E-fits, and most recently, E-jits. The importance of this, we should all be aware of and how to manage this. And for that, I would like to welcome Dr. Stephen Elias, who has had 20 years of experience in the field, founder of the ABF Fellow and Resident course. Yeah, welcome back.
All right, could you put up the, do I have to advance Nikos' slide? Area, I see. All right, and now you heard all the other acronyms, and now I will propose to you, since it's in some of the guidelines, it's ARTE, or ablation-related thrombus extension, which will cover whatever you use to treat the vein. So we'll just call it ART, or ablation-related thrombus extension. I'll tell you at the end where that came from most recently. So the things to consider, really, when you're thinking about the risk of ablation-related thrombus extension, well, as I said, is ART. You need to think about what's going on pre-procedure-wise, the patient factors that may lend to it, vein factors, and the physician's experience as well. Then during the procedure, obviously you want to look at the anatomy. Certain anatomies are a little more prone to it than others. What technique are you using? How long is the procedure? And are you doing any other adjunctive procedures at the same time of the ablation? And after the procedure, what are some patient factors? What are some of the symptoms you need to think about? So we're going to get down to the end about how to manage it. What are the recommendations, which are pretty straightforward. But more importantly, prevention is always better than treating. So pre-procedure, you want to ask these kinds of questions. Obviously previous history. They have a large body habitus. How much do they walk? What's the size of the vein? How about just in general DVT risk factors in general? And I think we kind of eyeball patients, but we all know there's various scoring systems that can tell you what is your risk of developing deep venous thrombosis, and the physician experience with whatever technique and technology that they're using. Is it something that person's just gotten into this? It's your third ablation, or is it your 3,000 ablation? Or if you've done 3,000 ablations, is this the third ablation you're doing with a new technique that you just started doing? You need to consider that as one of the risk factors, because we all know that early on people have a higher chance of developing thrombus extension in their experience versus once they get experience. So keep that in mind as well. And we all know there's all these scoring systems, but varicose veins in and of themselves are a risk factor for developing DVT, and we're treating patients most of the time with varicose veins. So keep that in mind. Not an insignificant number. So what is some of the classification? And this is EHIT because this is before we came up with something that covers more than just the thermal. This is the society recommendation from the American Venous Forum for Vascular Surgery. I want to tell you, I hope you saw it in my beginning, that I want to thank a lot of these slides are Lowell Kabnick slides. So he was obviously the corresponding author on this article. I'm sorry, let's go, how do we go back? Here we go back. Okay, so what are their guidelines? What are some of the risk factors? We're talking about risk factors. You can see here it's really a large saphenous vein diameter, previous history of VTE, and male sex. And this is something you need to really keep in mind as you're going forward and thinking, what do I need to do to prevent things? And then here's from the UK. In summary, you could see on the lower right, the risk factors to consider, the ones showing personal strong family history, known thrombophlebitis, reduced mobility, and then some of the others. So again, put it into your algorithm, so you want to think about things you can do to prevent these things. And the management recommendations here is, you can see on the left side, you may want to consider pharmacoprophylaxis before you do a procedure on patients who have high risk for perhaps developing DVT or thrombus extension. So here's the advice. You can see low risk. If there's an additional risk, maybe you want to have a week to 14 days of DOAC usually. And if someone's at a higher risk, you may even want to increase it. Just think about it, because what you don't want is to say, oh, everything's going to be fine, and then the patient develops a problem. So how about the European Society? This is in 2022. What are their recommendations here? They say patients who have superficial incompetence, risk assessment is recommended, so you really should always risk assess everybody, and it should be individualized, and if you do feel they have a higher risk, then you should think about some type of thromboprophylaxis. So again, identification of the person beforehand is better than treating them afterwards. How about during the procedure? Well, we already said a vein size greater than 10 millimeters. The length of the procedure, usually it's about 40 minutes or longer. One of the articles says, one of the studies, you're doing adjunctive procedures which add risk to developing a DVT, such as phlebectomy, adding foam, or you're doing multiple endovenous ablations on more than one vein. And that will also increase the risk. And when you do the procedure, are you concerned, is the thrombus like right at the junction? You would have liked it to have been a little further than that. Are you concerned? If you are, you may want to thromboprophylax that patient, or certainly bring them back for imaging relatively sooner. So again, here's the article in 2016, talking a Caprini score greater than 6, diameter greater than 10. This is a recurring theme, diameter greater than 10 for sure, and an operative time greater than 40 minutes. So again, keep it in mind when you're doing patients as to who's at a higher risk. Post-procedure, when do you image? Do you know your ART rate? You need to know it, okay? And again, as I said, if you are doing a new technique or a new technology, even if you're experiencing others, I feel, in general now, I do not routinely image patients post-procedure, a week or 10 days later, but if I'm doing a new procedure, and in general I do get a lot of new technologies to try, I will do this because you need to know what your rate is. You can't say, oh, with RF ablation, it's like nothing in my hands. But if you're doing something new, or you're taking on some new technology, you need to set the bar back to where you first started with the other technologies that you feel very comfortable with. So know what your ART rate is before you follow the quote guidelines. There are guidelines for when you're experienced and guidelines for when you're just starting something new. Obviously, if the patient is symptomatic, they're not doing the usual post-procedure, that most patients are. They're telling you a little more sore, my legs are a little more swollen, a little more tenderness in the groin. These are the people that you may want to consider the imaging. And if a patient says to me, they're really worried about a DVT, I'm getting an ultrasound. What's the big deal? This way you could, all you need is one patient that's worried about a DVT, they get a DVT and they say, doctor, I told you, why don't you take a look? And then obviously certain types of patients, maybe you want to be a little more cautious than others to make sure they don't have a DVT. But in general, this is what I would get concerned, and maybe I would image these types of patients. So Tom O'Donnell, this is in 2023. As usual, very erudite type of paper. He feels that the recommendations in the old SVS AVF recommendations to perform within 72 hours is not justified by the data. And you can read the data on the bottom here. But really, his point was, you can read the last sentence, which those who had imaging in the first postoperative week had a 3 times higher rate of, he said, EHIT, compared to those whose duplex was greater than 7 days. So we all feel there's an incidence, but it's a asymptomatic incidence that goes away after a week to 10 days. So if you don't image people early, you're not going to find it. And in general, I don't image people early if they're totally asymptomatic and they're doing what most patients are doing, and they don't have the risk factors I already elucidated for you. So this is now the guidelines that came out just in 2023. This is now part 2. And what's the consensus statement? In asymptomatic high-risk patients undergoing thermal and non-thermal saphenous ablation, early duplex ultrasound for ablation-related thrombus extension, that's where the ART came from. This is 2023 now from the guidelines, or DVT should be performed. So high-risk patients. So you need to identify your patients before you do the procedure and during the procedure if you're concerned with something. So it's not a, one thing fits all. You need to individualize. And then next, in symptomatic patients, clearly they recommend early duplex ultrasound. I mean, that's no surprise at all. And when should we care? That's what the title of this talk is supposed to be. You really care when it's class 3 and class 4, when you identify it, and that's what those that you're going to treat. Usually class 1 and 2, I would now call this ART, not EHIT, is when you can observe, bring the patient back maybe in a week and see if it's improving. And the great majority do improve, and that's what O'Donnell was saying. If you image after 10 days or so, the rate of identifying is much less. So what does the guidelines say? We suggest treatment with anticoagulation for ART3, say, weekly surveillance, cessation of treatment following the thrombus retraction. Okay? This is now controversial. We suggest treatment. Why is this doing this? Treatment anticoagulation, weekly surveillance, cessation treatment following thrombus retraction to the saphenofemoral junction. So in 2020, it was saying, yeah, do it. And here it's a little controversial now as to whether you should just do this. What's the other guideline? Treatment should be individualized, take into account all the risk factors. If somebody has a real, VTE and you follow the CHEST guidelines if they have a significant DVT or thrombus extension. The consensus here is to treat. So again, these are the things you want to consider. We already went through this, and once again, if you do things beforehand, the key to success is most battles are won before a single shot is fired. So think about identifying these people, and then you'll have a much lower rate. Thank you.
Our next speaker is world-renowned, board-certified vascular surgeon, former president of the American Venous Forum, founder of the Center for Vein Care at Stony Brook Medicine, and currently system chief for venous disease at Northwell Health. Please welcome New York in the house, Dr. Tony Gasparis.
Thank you. Reading that was basically the time it took me to get up here. So thanks for the introduction, and thank you, Sanjeev and CVR, for the invitation and for this fun topic, Peter. So management of vulvar varices, and I wouldn't say I'm the world expert on this, but we do see a lot of these patients. So vulvar varices are basically dilated varicosities, similar to what we see in the lower extremities, but obviously located in the labia major and minor. And it's really difficult to estimate what the prevalence is out there because NAP patients usually don't come in complaining about this, so it's significantly underdiagnosed. But in women with 2 or more pregnancies, it's about 20 to 35%. And that most of them regress postpartum, and it's felt that probably about 5 to 10% of these women will have prevalence of vulvar varices. Now, 90% of the women will have at least 2 or more pregnancies, and typically with each additional pregnancy, the varicosities develop earlier on, and they're less likely to regress after postpartum period. Location-wise, about a third of them are bilateral, a third of them on the right side, and a third on the left side. Now, earlier when I was outside, there was a comment Nikos made to Sanjeev saying that 1 in 6 in the world is of Indian descent, and actually Sanjeev corrected him that it's 1 in 5.5. And then the next comment was because the rest of the world is given up on sex. Right, Sanjeev? Was that, I don't know exact words, but obviously if that continues, the incidence and prevalence of vulvar varices is going to go even lower. But based on the connections, they occur based on the connection between the veins in the pelvis and the external genitalia, and really the drainage of the areas is through the external and internal pudental veins. So basically you have either external pudental draining to the saphenofemoral junction into the external iliac vein, or you can have them from the perineal source through the ovarian veins, and finally the internal pudental veins through drainage into the internal iliac veins. Looking at this, many people have seen this slide through Mark Meissner with the OPG exit points, looking at the obturator veins, the pudental veins, and the genitalial source. And again, all of these potentially have interconnections with the vulvar drainage. And this is a view from below, looking at those exit points from the pelvis. Now, clinically, these patients, most of them, and many of them, will be asymptomatic. They can have local symptoms with discomfort or itching, and they may have pelvic symptoms, obviously. And the source here could be either ovarian reflux or just pelvic periuterine veins. Clinical evaluation of these patients is very important, obviously. It's obvious on examination if you're looking. And pelvic ultrasound is just as important to identify what the source and the interconnections with the vulvar veins are. And if there's ovarian reflux, if there's compression, obstruction, and if there's internal iliac interconnections. Axial imaging may be helpful, and obviously venography would be indicated if plans are to proceed with intervention. Now, talk about intervention, treatment options. Here again, like anything in medicine, focus on the clinical presentation, and it could be anything from conservative therapy to more invasive treatments, which we'll cover. With the indication for treatment, obviously, if they have pelvic symptoms, if they have recurrent vulvar veins and or lower extremity symptoms after treatment, or if they have persistent symptoms even after local treatment of the vulvar varices. With treating the pelvis, there's obviously a rich communication between vulvar varicosities, as we saw earlier, with the pelvic veins, and in treating the ovarian reflux, if there's present there, can significantly reduce the size of the varicosities, not always eliminating them. And you may have to be more selective in treating the tributaries of the internal iliac to get rid of whatever residual varicosities are in the vulva, or directly treat the varicosities in the vulvar area. This is one of the few papers out there looking at coil embolization, and you can see that although only 12% of the lower extremity varicosities disappeared after embolization, almost 90% of the vulvar varices disappeared after ovarian vein embolization. Sclerotherapy indications, obviously, for someone comes in for cosmetic reasons, if they have local symptoms. Typically, it would be nice not to have an obvious connection with a large tributary in the external iliac to have good results, and selectively, with the smaller varicosities in the area. Patients use supine, put them in reverse Trendelenburg. You can use liquid or foam sclerosant. Obviously, after injection, manual compression in the area, and use a V2 support afterwards. This could be done, again, either just visually or using ultrasound guidance, this is before and after with sclerosing the vulvar varicosities. And again, like I said, either ultrasound guidance or you can do this through fluoroscopic guidance to determine how much sclerosant to use and avoid spillage into the internal iliac. And this is actually images from Steve, so thanks, Steve, for getting this to me. And you can see there the stagnation flow after injecting the varicosities. Local phlebectomy, I've done 2 patients this, not a fun thing to do for either the patient or myself, but usually we reserve this for moderate, larger varicosities. If there's a disfigured labia, you may want to get a GYN or plastic surgeon involved with this. Typically, even if they have no pelvic symptoms and they have really large vulvar veins, I would suggest treating the pelvic source, even though there's no pelvic symptoms, because many of these veins will regress or get smaller and will respond with just sclerotherapy. And I think that's one of the reasons I don't see too many patients that need phlebectomies. But the patients that I have done, it's really not that complicated. Hemostasis is easily achieved, and this is from a paper showing you large varicosities where you remove it, and excision also of a disfigured labia. Just from an algorithm perspective, again, looking at clinical presentation, is the patient asymptomatic? Do they have local symptoms or pelvic symptoms? And that's really kind of guide you as far as if you're going to treat the pelvis or not, or just treat locally. If you're going to treat the pelvis, obviously identify what the pathology in the pelvis and treat appropriately. And then as far as locally treating the varicosities, are they large or moderate size to determine if you're going to go with foam sclerotherapy or if you need a little bit more phlebectomies. I'm not going to go through this quickly. Oops. So basically, if they're asymptomatic, small varicosities, sclerotherapy. If they're large, phlebectomy. If they have local symptoms and they're small, sclerotherapy. If they're large, look at the pelvis, treat the pelvis, and again, the vast majority of the time, you'll get the varicosities down to a size that you can just treat locally with sclero. And then if they have pelvic symptoms, attack the pelvis first, and then address the varicosities. Thank you.
Our next speaker is going to be Virgil. She's a well-renowned national and international speaker, but she is known for her love and the management of lipedema. She spearheaded a conference that established the standard of care for patients with lipedema, and thanks to her, we can now properly code for these patients as she helped us in 2020 develop this code system. I'd like to welcome Dr. Karen Herbst.
Thank you so much. I hope you can hear me. So I'm going to talk about, is lipedema a collagen vascular disorder? And I hope you all know what lipedema is at this point, but it's a disease that primarily occurs in women where increased fat tissue grows primarily on the limbs, but also the lower abdomen, and it can grow to great proportions, causing social, mental, and physical dismobility. Next slide. This is my disclosures. Next slide. Last time I was at CVR, I had a great time. You guys have great conferences, and I was with my friend Lindy McCutcheon. Next slide. So lipedema is, in my opinion, and most anatomy books, a connective tissue disease because there are 3 types of connective tissues: loose, dense, and specialized. Adipose tissue is part of loose connective tissue, but it's intimately associated with other connective tissues like tendons and ligaments or sheets of connective tissue right under the skin. Together, connective tissues working together make fascia. Next slide. And this is an example of fascia. You can see that on the bottom, there's a sheet of fascia, and right next to it is adipose connective tissue, and then that's directly next to muscle. And fascia maintains vessel patency, it separates muscles, and it encloses organs. Next slide. And this is a picture of, next slide. All right, next slide. Oops. Am I missing a slide? Sorry, can you go back one? Okay. That's okay. So as adults, we know that we can gain fat tissue and lose fat tissue. And there are different places where our adipocytes come from as adults. And sometimes this is fortunate and sometimes it's unfortunate. But adipocytes can come from the bone marrow, from vascular stromal cells, from parasites, from endothelial cells, and also from superficial fascia. So the fact that adipocytes can come from connective tissue itself really makes it firm that adipose tissue is a connective tissue. Next slide. So, next slide, please. So this is an example of adipose connective tissue, and I know it's a little bit blurry, but you can see the adipocytes on the bottom of the slides, fibers on the top of the slide, and together these fibers and adipocytes make up adipose tissue. But you can see that if we didn't have connective tissue fibers as an intimate part of adipose tissue, that the adipocytes would spill away and be metabolized, and we'd lose them all from our bodies. So having those connective tissue fibers helps give it shape. Next slide. And you can see on this picture a red blood vessel, intimately associated with fibers, and also you can see that little yellow blob of adipose tissue. So adipose tissue also feeds blood vessels as well as provides a scaffolding for them. Next slide. So let's look at the difference between adipose connective tissue in women and men. You can see on the left in female fat, there are much larger adipocytes, and you can see how thin the septae is. Whereas if you look at the male fat, there are a lot more adipocytes right under the skin, but they're very small, and the septae are really dense. If you were to hang a weight on this tissue, which the paper by Rudolph et al. Did, they showed that male fat was much stronger than female fat. So perhaps the strength of fat tissue is playing a role in the pathophysiology of lipedema. So let's go to the next slide. I think you can clearly see here under the skin that there are some thickened fibers in this patient with lipedema. Those fibers, if you were to touch them with your finger, are really hard. Now, our septae, separating our adipocytes from one another, are very thin and mobile, which is why we're able to move the tissue on our bodies. But in lipedema, these fibers are really firm and tight, and fibrotic, and that is part of the physiology of lipedema and really firms it up as a connective tissue disease. There's a lot of hardness within and around pearls of fat tissue, as shown by the dark arrows here. And then you can see that there's some scar tissue under the skin. So there's fibrosis in many compartments in lipedema. Next slide. And this is a picture by Dr. Jamie Schwartz, where he's actually incising down to the deep fascia, so right above the muscle. And here, fat has almost completely replaced the deep fascia. And what you're seeing when he cuts it open is fat tissue, because fat has also infiltrated around the muscle. And that fat around the muscle actually makes it difficult for muscle to function properly. So when lipedema is on the calf muscle pump is not effective. Next slide. We were one of the first to show that many women with lipedema had hypermobile joints. And we think that hypermobile joints are a marker of weakness in connective tissue, including the connective tissue associated with blood and lymphatic vessels. Next slide. Sorry, next slide, yeah. But we were not the first to show there was hypermobility, at least in pictures. This is a picture from 1974, and I think you can see that the knee is very hypermobile in this woman, and you can see the classic pads of fat tissue under the knee and also around the ankles. Next slide. So to give you an idea of how different or weak, or that there's a loss of elasticity in lipedema tissue, I'm going to show you some lymphography pictures. So on the left side, you're going to be looking at normal tissue. So that big black Rorschach spot is where they inject the dye. And then that dye gets taken up into the lymphatic collectors, which are nice and linear and normal. And you can see that that dye is very well confined. But on the right side, look at the lipedema tissue. You can see that dye is spreading out like a flame. So the tissue is actually accommodating the dye for much longer and for a greater extent before it enters the lymphatic vessels. And you can see the lymphatic vessels are nice and linear, and they appear to be normal. So there is a dilation of the pre-lymphatic space in lipedema. There's very low resistance in the tissue, so a loss of elasticity. Next slide. So flow through normal tissue or controlled tissue should be from blood vessel through the tissue, and then that fluid gets taken up by the lymphatic vessels. Next slide. But in lipedema, we think that fluid comes out of vessels and it is stagnant in the tissue. It stays there longer, which completely changes the physiology. So the tissue ramps up glycosaminoglycans, which bind the water, and also immune cells are recruited in because the fat cells are getting displaced from their oxygen source, the capillary, and therefore this is a more hypoxic environment, more inflammatory. Next slide. If you read through the plastic surgery literature, they say that slow flow of fluid through tissue results in lymphatic fluid stasis and significant subcutaneous fat deposition. So we think that the poor elasticity of lipedema connective tissue is contributing to its pathophysiology of growing fat. That fat becomes inflamed and then fibrotic and then difficult to lose by diet or exercise. Next slide. Now, I mentioned that vessels are also made of connective tissue. Here we're looking at blood vessels in the dermis of the skin of women with lipedema, and we compared them to controls. And there's leaky vessel physiology going on here. The white spaces around this vessel, the vessels are marked by the little white asterisks. And the white space by that white arrow is fluid. So there's fluid around the vessels that should not be there. The dotted arrow shows that there are more immune cells in the tissue, and the rounded cells by the solid black arrows show that the cells are separating, allowing fluid to enter the tissue. And on the right side, we showed that there were more leaky vessels in the thigh of women with lipedema compared to controls. Next slide. So a group out of Vienna used artificial intelligence, which is going to become more prominent in the literature as time goes on. They used AI to identify whether the adipocytes that came from liposuction samples, which they call stromal vascular fraction, could form normal endothelial cells in culture or leaky endothelial cells. And they found that control tissue had normal endothelial cell or blood vessel cells, and lipedema tissue had leaky endothelial cells. Next slide. So they went on to try and figure out why this is happening. So they took the liposuction cells and they grew them up in culture. Then they took that fluid, which they call a secretome, and they put it onto normal endothelial cells in culture. And they found that if they took control fluid and put it on the endothelial cells, that there was no leakage. But if they took the secretome from lipedema tissue, there was a leakage of the vessels. So there's something being secreted from the lipedema tissue that is causing that leakage. Next slide. So I want to end, next slide. I want to end with this concept, and that is that normally we think there are a couple fat layers on the leg, as shown here on the left. But actually there are 3 fat layers on the medial side of the leg, and that's where the greater saphenous compartment is. So you've got your superficial fat, your deep fat, and then you've got fat within the saphenous compartment. And the saphenous compartment contains, in a simplified manner, a nerve, a vein, and a lymphatic vessel. And that lymphatic vessel comes from the superficial lymphatic system. Next slide. So when you contract the muscle pump of the leg, the saphenous compartment actually thins, which is shown on that right side, pushing not only venous fluid upward, but lymphatic fluid upward. And I was listening to the pump lecture during breakfast, and we know that pumps actually do this as well. Next slide. But in lipedema, we think that fat is growing in multiple compartments. And I showed that earlier on that slide by Jamie Short, showing that fat had infiltrated the deep fascia, but also into the muscle compartment. And my friend, Dr. Jose Luis Simaro from Madrid, think that fat grows within the saphenous compartment as well. So when that muscle pump contracts in lipedema, that saphenous compartment cannot contract. In fact, it puts pressure on the vein. And we think that even if we don't see a lot of fat in that compartment, what might be happening is that there's a lot of fibrosis, because I think I've convinced you that there's a lot of fibrosis in lipedema tissue. And this prevents that muscle pump from transferring that pressure to the saphenous compartment. Fluid does not move effectively up the leg, and in fact, stays within the calf compartment, causing fat to grow. Next slide. And this can happen for the lesser or smaller superficial saphenous vein. And you can see that the saphenous vein runs from the lateral malleolus up the back of the leg into the popliteal space. Next slide. And so what we think is happening is that fat that grows within that saphenous compartment, or that fibrosis that contracts that saphenous compartment, drives the fluid down the leg, and it deposits on the outside of the foot near the lateral malleolus, causing a fat pad to grow. So the next time you see a lipedema patient, you can palpate and see if there is a pocket of fat there, and then you could think in your head, they must have either saphenous fat within that compartment or fibrosis. Next slide. So I want to conclude by saying that I hope I've convinced you that fat or adipose tissue is a connective tissue. If fat is growing abnormally in lipedema, then lipedema is a connective tissue disease. And connective tissue also is part of blood vessels, and it's intimately connected together, forming fascia. And we think that lipedema tissue may be weaker because of hypermobile joints, some sort of connective tissue mutation, and also just because of the female sex, which makes the tissue weaker. We think the weak tissue causes vessels to become leaky and inflammation to develop, and inflammation makes fat grow, damaging fascia and creating a vicious cycle. We also think that fat growth within the saphenous compartments may be part of the physiology of lipedema, and it may be part of the physiology of obesity. And I would love to see CVR look further into this and get a lot more information, because you could do that actually very quickly. Next slide. Next slide. I just want to say thank you.
Okay, our last speaker for this session comes to us with over 30 years of experience in the healthcare industry, from direct patient care to hospital leadership. He's a graduate from the University of Alabama and played professional baseball with the Montreal Expos. Please welcome CEO Center for Vascular Medicine, as well as the Executive Director of the Lac and Paul Vein Foundation, our good friend, Rick Kennedy.
Thank you.
Good morning. You can go to the slide deck. Thank you. No. Oh, there we go. Great. Good morning. My name is Rick Kennedy with the Center for Vascular Medicine and the Lac and Paul Vein Foundation, and it's my honor to spend the next few minutes sharing with you an update on the good work of the foundation. The foundation began in 2014 and was created by Dr. Sanjeev Lac-and-Paul with encouragement from his father, Dr. V. Lac-and-Paul. I think it's always important to remind ourselves of our purpose, and at the Lac and Paul Vein Foundation, our mission is to improve venous disease outcomes and awareness through philanthropy, innovation, education, and research. Our goal has always been to simply share what we've learned in the care and treatment of the complex venous patient, and we accomplish this through publication, as well as by making it a part of our training and our education for the Lac and Paul Vein Foundation research fellows and students. Our leadership team is comprised, of course, of Dr. Sanjeev Lac-and-Paul, myself, and our Director of Research, Dr. Peter Pappas. In addition, we are joined weekly in our research collaboration meetings by our faculty, including Dr. Teresa Soto, Dr. Gaurav Lac-and-Paul, Dr. Zoe Deol, and our research fellows, who this year include Mike Nguyen, Natalie Ma, Zach Snyder, and Siona Satwa. This is all unpaid work, and it's undertaken purely for the love of what we do. And I'd like to thank each of our leaders and our contributors for what they do to advance the reputation that we're also very proud of every day. Our work can be seen today in publications including the Journal of Vascular Surgery, Venous and Lymphatic Disorders, Phlebology, and the International Journal of Angiology. At the direction of Dr. Pappas, we choose topics in our field that, in his words, are cutting edge and disruptive. Since 2018, the foundation has been recognized as the primary sponsor of over 20 publications in both areas of superficial and deep venous disease. Through this significant contribution to the knowledge in the venous space, the foundation has come to be recognized and a leader in the industry. On average, it takes anywhere from 200 to 300 hours of work to bring an idea from its infancy through to acceptance for publication, and a good deal of this work is performed by our fellows. They range anywhere from rising seniors in high school all the way up to fourth-year medical students. And as a part of our commitment to them, when they contribute a meaningful amount of work to a study, they are given the opportunity to present that at a national meeting, to write the manuscript, and ultimately to be recognized as the first author in that published work. This is part of the way that the foundation gives back, and by allowing these students to be recognized for their passion and for their intellect. As you can imagine, this opportunity proves invaluable when it comes time for them in this very hyper-competitive world of undergraduate, graduate, and medical education. And so we're proud of what we've accomplished, but in particular are most humbly honored to have had the opportunity to further the careers of so many young students and scholars. Looking back over the past year, I wanted to take a moment to recognize those students who have made us so proud with their achievements. Tess Calcagno at the Cleveland Clinic, Neil Gadok at the Rutgers New Jersey Medical School, Arjun Narasimhan at the GW University School of Medicine, Priya Lac-and-Paul at the University of Pennsylvania School of Dental Medicine, and finally Sydney Pappas at Georgetown University. Each of these students was published as first author in either the Journal of Vascular Surgery or Phlebology for an LVF-sponsored paper. In speaking with each of them, both during and after their research fellowship, they told us that they gained invaluable experience and confidence by working with their LVF mentor and by being allowed to be involved in important medical research. Each of them was prepared for their school interviews by their mentor, and as you see, each has achieved at the highest level. So we're so very proud of each and every one of them. Finally, I wanted to just speak for a moment on the Sushruta Award. This evening, of course, we'll be bestowing the 2024 Sushruta Award on the recipient. And it's such a great opportunity for the foundation to advance someone in our field who has contributed to the world of venous and lymphatic medicine in many meaningful ways. Each year since 2019, the LVF seeks nominations from our colleagues around the world. We meet and we deliberate over many qualified candidates, and we select the person who best represents the foundation's goals of innovation, scholarship, teaching, and research. The award is not only our way of recognizing those who have truly gone above and beyond, but as a part of our mission for philanthropy, we offer a $10,000 donation in the honoree's name to the not-for-profit of their choice. So what's next? At the foundation, we continue with our work, and we're currently active in 6 research projects. Of course, this evening we'll award the 2024 Sushruta Award recipient. But going forward, we're asking for some of your help and your support. Please spread the word and be an ambassador for the good work of the foundation. Send nominations for the Sushruta Award. Refer young, promising students to serve as fellows on our research council. Send ideas to Dr. Pappas for future studies. And finally, remember that each of you participates every day in our foundation by taking superlative care of our patients. It's only through this good work that we have access to such a large encyclopedia of data that allows us to further the mission of the foundation. On behalf of the Drs. Lackenpaul, Dr. Pappas, and myself, I want to thank you today for your attention and for your support of the foundation. Thank you.